This is a middle-aged lady in her late 40s actually, presented with bilateral corneal opacities. Of course, the left eye was worse than the right eye. The cataract also probably the same in both eyes, and obviously she opted for the left eye to be operated first. Although I would have loved to operate the right eye, that seemed much easier. Anyway, here's how the surgery went. These look like sclerocorneal opacities, old sclerocorneal opacities. Unfortunately, initial part of the surgery is not there. It started where I stained the capsule with trypan blue, and I've expressed the trypan blue and the air with 2% HPM. Now watch this step. This is an important step. See, as I turn the globe, I've just put on my coaxial illumination here, not the microscope light. Notice how the red reflex gets much better at a certain angle, and this is very important for you to know, because this particular principle you have to use to do your capsular axis. So you just turn the globe, get the best reflex possible, and I would suggest just go under coaxial illumination, put off your microscope light, and you can see I've got a pretty neat rexus. There is a bit of a blind spot temporarily, but I can manage. I can see the flap, the folded flap, and it's easily done. Just checking that it is complete. You have to do that. Okay, it looks complete and it looks like a good rexus. I then go ahead and do the hydrodissection. Can't see the wave, but I can see the forward movement of the nucleus and epinucleus and everything else with it. So that looks like a good hydrodissection. Initially I started off trying to chop this nucleus. It didn't work. It's a very soft nucleus, so I knew that, and shifted my parameters to stop and chop, and that's what I am showing actually. So that's the part of that trench, and just deepening and lengthening that trench. I need to get this crack. These soft cataracts can be pretty not difficult, but they can be pretty irritating, because things just do not go smoothly sometimes with them. So I'm trying to make a deep trench and also a long trench. That looks okay. So going towards that mid periphery, at least the periphery of the hardcore nucleus, that I think is the hardcore nucleus. Yes, I've got the crack. So at least that first part is good. Trying to propagate that crack all the way through. Looks like it's done, although I'm not so sure about the proximal part. And look here, it's very difficult when you try to get that epinucleus. Obviously it doesn't hold, so I go for the hardcore nucleus, and that's a better hold. Get it out, and this is very low. You don't need much power. It's hardly 30% or hardly 20% power, but I've got 400 millimeters of vacuum and 40 ml flow rate, so that is helping. And I go for the other piece, and it looks like it has come out in a piecemeal, so probably there was an attachment. Not to worry, we got most of it out, so I'm not too worried about it. I just don't want to keep coming out of the anterior chamber and risk my pupil shutting down on me, because that will make the surgery extremely difficult. So I'm trying to just take out everything with my Phaco probe, but you have to be extremely careful. There's a bit of a nucleus there, got it out, and then obviously I look at the epinucleus and I realize that no way this epinucleus is going to be removed by my IA probe. So I have to take it out with my, it's pretty thick epinucleus. It has to come out with my Phaco probe. And yeah, I've gone into my aspiration parameters. I'm trying to just tease it out of the bag. Not very easy. So obviously the dissection could have been better, although it's good enough. Most of it has come out. So there is a bit of a cortex which I should have just left to my bimanual. However, we're all prone to silly things. I go with my Phaco probe. So after I get a bit of it, I realize there's no point in risking. I go in with my bimanual, and that's much more safely done. So I'm targeting the superior cortex first, the subincisional, then I go for the rest. Keeping on rotating the globe, and against the red reflex, it's much better to appreciate where the cortical fibers are. I also remove the, polish the posterior capsule as well. The lady has enough opacities. We don't need the posterior capsule opacified as well. So once that's done, I'm just checking, making sure I do a thorough job on the posterior capsule. This is very low parameters, just 5 ml aspiration and 5 millimeters of mercury aspiration vacuum and 5 ml flow rate. So very safe. And I am not very happy with how that wound is leaking. The whole peripheral cornea, even pre-op, it's thinned out. So before coming out, I put in some HPMC, come out. I'm going to inject my IOL. It's a single piece hydrophobic foldable IOL. So that goes directly into the bag. And I remove the HPMC now, and I am going to watch this AC, watch the wounds, and I don't like what I see. So I put back the HPMC into the chamber, suture my main incision, and that's not going to be enough. I have to suture the paracentesis as well. But before I suture the final paracentesis, I just remove all the HPMC from the chamber and suture that final paracentesis. You have to obviously push in all the knots, and I'm hydrating the wounds. I've already put in my intracameral antibiotic, and I conclude the surgery. And this is the first day post-op picture. Vision is 6/18 with pinhole 6/9. Few Descemet's folds are there, but nothing great. And 4 days later, it's even better. The cornea has cleared much more. Vision has improved to 6/12. Thank you so much for watching.